Outlines: Randomized Controlled Trial (RCT), Non-Randomized Concurrent Control Studies, Historical Control and Database. Randomized Controlled Trial (RCT). Randomized Controlled Trial (RCT) is defined as a clinical trial in which the participants are assigned randomly to different treatment groups. Thus, each participant has a known and equal chance of being assigned to a given group, and the group assignment cannot be predicted. Randomized experimental design is the preferred method of research for evaluating treatment effects in health research, since it provides the highest degree of control over a research study and allows the researcher to draw causal inferences with the highest degree of confidence. They use a systematic methodology that allows controlling for confounded variables. In real life, clinical experiments never control for all confounders. However, RCT design offers the most convincing evidence of the effect of one variable has on another. Causal inference. Causal inference is the statistical method to determine variable causal relation between variables. It is often more difficult to find the causal relationship between variables than to find the correlation between variables. For example, a study showed that girls who have breakfast normally have light weight than the girls who don't, and concluded that breakfast helps to lose weight. But in fact, the two events just has correlation, not causal relation. Maybe the girls have breakfast have better lifestyle, like exercise frequently, which finally make them lightweight. Update. For the above example, there are three possibilities. Eat breakfast make girls slim, or slim girls like to eat breakfast. In this case, the causation is reversed, or as the above statement, girls who eat breakfast tend to regularly exercise, which eventually make them slim. To inference the causal relation, it is often needed to control the experiment by doing some random assignment to the subject, like in this example, random assign girl to eat breakfast or not, and after some period of time to see whether the effect of eating breakfast makes them slim compared to the other group. It is also need to do a lot of control of other variables which may affect the result. So in the experiment, only one variable dominates the result, and by doing this, we can do causal inference of the relationship between variables. Randomized Control Trial (RCT). RCTs are usually utilized to access treatments. Efficacy refers to what the intervention accomplishes in an ideal setting, or effectiveness refers to what the intervention accomplished in actual practice, taking into account incomplete adherence to the protocol. In terms of superiority, to determine if a novel treatment is better than a placebo or a standard intervention. Non-inferiority, the novel treatment is no worse than a placebo or a standard intervention. Or equivalence, analogous to non-inferiority, but permit of the novel intervention is no better than a placebo or a standard intervention. MP efficacy of a drug or treatment, the maximum ability of a drug or treatment to produce a result regardless of dosage. A drug passes efficacy trials if it's effective at the dose tested and against the illness for which it is prescribed. Phase 2 clinical trials gauge efficacy, and Phase 3 trials confirm it. Randomized Control Trial (RCT). These studies may analyze a conversion between treatment and not treatment, or placebo, different treatment strategies, or different dosage intensity of the same treatment. The term randomized defines the random assignment to each study group.
This implies a blank in a baseline characteristic known and unknown amongst patients groups, reducing confounding factors and improving internal validity of the result. Why randomize? Researchers demand randomization for several reasons. First, participants in various groups should not differ in any systematic way. In a clinical trial, if treatment groups are systematically different, trial results will be biased. Suppose that participants are assigned to control and treatment groups in a study examining the efficiency of a walking intervention. If a greater proportion of older adults is assigned to the treatment group, then the outcome of the walking intervention may be influenced by this influence. The effect of the treatment would be indistinguishable from the influence of the implants of covariates therapy, requiring the researcher to control for the covariates in the analysis to obtain an unbiased result.
Why randomize? Second, proper randomization ensures no a prior knowledge of group assignment, i.e. allocation concealment. That is, researcher, participant, and others shouldn't know to which group the participant will be assigned. Knowledge of group assignment creates a layer of potential selection bias that may taint the data. Schools and Graham stated that trials with inadequate or unclear randomization tended to overestimate treatment effects up to 14% compared with those that used proper randomization. The outcome of the trial can be negatively influenced by the inadequate randomization.
How to randomize? Many procedures have been proposed for the random assignment of participants to treatment group in a clinical trials. Common randomization techniques including simple randomization, block randomization, stratified randomization, and covariates adaptive randomization. Each method is described along with its advantage and disadvantage. Non-randomized concurrent control studies. Controls in this type of study are participants treated with the new intervention at approximately the same time as the intervention group is treated. Participants are allocated to one of the two groups, but by definition, this is not a random process.
Non-randomized concurrent control studies. An example of a non-randomized concurrent control study would be a comparison of several results of patients treated at two institutions. One institution using a new surgical procedure and the other using more traditional medical care. To some investigators, the non-randomized concurrent control design has advantages over the randomized control design. Non-randomized concurrent control studies. Those who object to the idea of ceding to chance the responsibility for selecting a person's treatment may favor this design. It is also difficult for some investigators to conceive potential participants of the need for randomization. They find it easier to select a group of people to receive the intervention and would prefer to select the control group by means of matching key characteristics. Non-randomized concurrent control studies. The major weakness of the non-randomized concurrent control study is the potential that the intervention group and control group are not strictly comparable. It is difficult to prove comparability because the investigator must assume that he has information on all the important prognostic factors. Selecting a control group by matching more than a few factors is impractical, and the comparability of the variety of the characteristic would still need to be evaluated. In some studies, an investigator is unlikely to find real differences which may exist between groups before the intention of interventions, since there is poor sensitivity to detect such differences. Even for large studies that could detect most differences of real clinical importance, the uncertainty about the unknown or unmeasured factors is still of concern. If there, for example, some unknown and unmeasurable process that results in one type of the participants being recruited more often into one group and not into the other. If all participants come from one institution, physicians may select participants into one group based on subtle and intangible factors. In addition, there exists the possibility for subconscious bias in the allocation of participants to either the intervention or control group. One group might come from a different socioeconomic class than the other group. All of these uncertainties will decrease the credibility of the concurrent but non-randomized control studies. For any particular question, the advantages of reduced cost, relative simplicity, and investigator and participants' acceptance must be carefully weighted against the potential biases before a decision is made to use a non-randomized concurrent control study. Historical controls and databases. In historical control studies, a new intervention is used in a series of participants, and the results are compared to the outcome in a previous series of comparable participants. Historical controls are thus, by this definition, non-randomized and non-concurrent. Strengths of historical control studies. The argument for using historical control design is that all new participants can receive the new intervention. As argued by Jehan and Frederick, many clinicals believe that no participant should be deprived of the possibility of receiving a new therapy or intervention. Some require less supportive evidence than others to accept a new intervention as being beneficial. If an investigator is already on the opinion that the new intervention is beneficial, then she would most likely consider any restriction on its use unethical. Therefore, she would favor a historical control study. In addition, participants may be more willing to enroll in a study if they can be assured of receiving a particular therapy or intervention. Finally, since all new participants will be on the new intervention, the time required to complete recruitment of participants for the trial will be cut approximately in half. This allows investigators to obtain results faster or do more studies with given resources. Alternatively, the sample size for the intervention group can be larger with increased power. Jehan emphasized the ethical advantage of historical control studies and pointed out that they have contributed to medical knowledge. Lasagna argued that medical practitioners traditionally relied on historical control when making therapeutic judgment. He maintained that while sometimes faulty, the judgments are often correct and useful. Typically, historical control data can be obtained from two sources. First, control group data may be available in the literature. These data are often undesirable because it is difficult and perhaps impossible to establish whether the control and the intervention groups are comparable in key characteristics at the onset. Even in such characteristics were measured in the same way, the information may not be published, and for all practical purposes it will be lost. Second, data may not have been published but may be available on computer files or in medical cards. Such data on control participants, for example, might be found in large centers, which has several ongoing clinical investigations. When one study is finished, the participant in that study may be used as a control group for some future study. Centers that do successive studies, as in cancer research, will usually have a system for storing and retrieving the data from past studies for use at some future time. The advent of electronic medical record may also facilitate access to data from multiple sources, although it doesn't solve the problem of non-standard and variable assignment or missing information. Limitation of historical control studies. They are particularly vulnerable to bias. Mortial cited a number of examples of treatment for cancer which have been claimed on the basis of historical control studies to be beneficial. Many treatments in the past were declared breaking through on the basis of control data as old as 13 years. Pocock identified 19 instances of the same intervention having been used in two consecutive trials employing similar practices at the same institutions. Theoretically, the mortality in the two groups using the same treatment should be similar. Pocock noted that the difference in mortality rates between such a group ranged from minus 46% to plus 24%. 4 of the 19 comprehension of the same intervention showed different significance at the 5% level. An improvement in outcome for a given disease may be attributed to a new intervention when in fact the improvement may stem from a change in the patient population or patient management. Shifts in patient population can be subtle and perhaps unpredictable. The results would have been misleading had this been a historical control study and had a concurrent randomized comparison group not been available. On a broader scale, for both known and unknown reasons, in many countries trends in prevalence of various diseases occur. Therefore, any clinical trial in those conditions involving long-term therapy using historical controls would need to separate the treatment effect from time trends and almost impossible task, e.g., the changes over time in rates of the leading causes of death in the US. Role of historical controls. Despite the limitations of the historical control study, it does have a place in scientific investigations as a rapid, relatively inexpensive method of obtaining initial impression regarding a new therapy. Such a study can be important. This is particularly so if investigators understand the potential basis and are willing to miss effective new therapies if base works in the wrong direction. Pyler et al. Identified several features which can strengthen the conclusion to be drawn from historical control study. This include a prior identification of a reasonable hypothesis and advanced planning for analysis. In some special cases, where the diagnosis of a disease is clearly established and the prognosis is well known, or the disease is highly fatal, a historical control study may be the only reasonable design. The result of penicillin in treatment of pneumococcal pneumonia were so dramatic in contrast to previous experience that no further evidence was really required. Role of historical controls. The use of prospective registries to characterize patients and evaluate effects of therapy has been advocated. Supporters say that a systematic approach to data collection and follow-up can provide information about the local patient population and can aid in clinical decision making. They argue that clinical trial population may not be representative of the patient actually seen
by a physician. Mon et al. Described the use of database derived from clinical trials to evaluate therapy. They stress that the high-quality data obtained through these sources can reduce the problem of the typical historical control study. In a broad definition, a registry is a collection for one or more purposes of standardized information about a group of patients who share a condition of experience. The definition is similar to the general definition of a database. A database can be defined as a collection of data or information, typically organized for ease and speed of search and retrieval. The definition illustrates that a registry is a certain type of database and has no inherent design features.
The use of databases has expanded in recent years. Outcomes research has burgeoned because of the relative ease of accessing huge computerized medical databases. The primary reason have been the speed and lesser cost of such analysis compared with clinical trials. Databases can be also used to identify adverse events. Examples are comparison of different antihypertensive agents and risk of stroke and cyclooxygenase 2, COX2, inhibitors and risk of coronary heart diseases. In addition, databases likely represent a much broader population than the typical clinical trial and can therefore complement clinical trial findings. This information can be useful as long as it kept in mind that users and non-users of a medication likely have different characteristics.
Others have emphasized limitation of registry studies such as potential biases in treatment assignment, multiply comprehension, lack of standardization in collection and reporting data, and missing data. Another weakness of prospective database registries in that they rely heavily on the validity of the model employed to analyze the data. There is no doubt that analysis of large databases can provide important information about diseases occurrence and outcome, as well as suggestion that certain therapies are preferable. As noted above, they can help to show that the result of clinical trials conducted in selected populations appear to apply in broader groups. At the present time, however, it is no subtitle for randomized clinical trial in evaluating whether one intervention is truly better than another.